Dr. Julio Calderone, one of my favorite guys that I've met in my time here in South Florida, because you are a gifted professional that does amazing work with very, very difficult clients. That's been my experience. Maybe you don't see them as difficult, but I mean, you are an amazing guy, full of life, and I really enjoy being around you. So thanks for spending
Thank you, Terry.
time with
really
us.
Appreciate it. Really appreciate it.
Julio, how and why did you become a psychiatrist?
Terry, there's always a story, right? There's always a story behind it. So I actually majored when I went to undergrad at the University of Miami. I actually majored in biochemistry. So I was always kind of interested in sort of let's say more of the biochemistry of the body. And throughout high school, my mother actually worked at the University of Miami School of Medicine. So she would hook me up with these summer jobs in the Department of Neurology. Wow. So for many years, every summer, I would work basically studying stroke models and got really interested. I mean, we worked with rat brains. So it wasn't human brains, but it basically using it as a model to help us understand how to prevent and treat strokes. And so I got very interested in the biochemistry of the brain. And then at the University of Miami, back in that day, I was there 1988 through 1992. And back at that time, they had a program called The Open Door. And it was a peer counseling hotline and service where students from the university, undergrads, would actually be like peer counselors to students that were in crisis at the university. And we had two options. You could either, literally, we were housed in an apartment there on campus. So people could actually either come on, like show up in person, or they could actually call us on a hotline. So we were dealing with potentially people that, students that may be suicidal or may have had any kind of issue. So we underwent basically like a 6-week training program on how to be a peer counselor. And I'll be honest, I developed a crush on the female psychologist from the counseling center who eventually became my therapist. I don't think I ever told her that I developed a crush on her, but later on in life, I actually went back into therapy myself afterwards when I was in med school, and I went to see her. She was now in private practice. So anyway, I fell in love with the idea and imagine being able to merge my interest in the brain and brain chemistry with actually being able, I loved the idea of working in therapy and helping others. And I was one of these kind of unicorns, you don't really know where your interests come from. I don't know. I always had an interest in analytic thinking and psychoanalysis and kind of that field of, sort of Freudian psychoanalysis. So it was just kind of like a wonderful merging. And it was like bringing these two worlds together. So I could both be a doctor, which I had always wanted to be, but also help people in terms of the psychotherapeutic part of it. So
you were chosen for.
I have to tell you, I did always feel like I had a calling. I will tell you, I went through a wanting to be a priest phase. I discovered women, and then I left the priesthood behind. But I actually went to a Catholic high school where the seminary was on the other, like literally the high school was on one side and the seminary was on the other, and there was only like a little walkway in between. So it wasn't going to be a big deal to just skip over and go to the priesthood. But my nickname was Father Julio in high school. It was not good for picking up girls. Okay, Father Julio was not. But I think I found the real calling.
Yeah.
Okay.
But the bottom line is you were chosen to do something where you were going to be helping people and relating to people because you have that ability of to connect with people, and people love being around you. And you are a psychoanalyst as well as a psychiatrist. So that means you have. Tell me, what does that mean that you're a psychoanalyst?
It means I'm crazy. But so I think, Terry, part of the problem is that. And it's interesting because it's not just in the field of psychiatry. I think even in the field of psychology, a lot of psychology and psychiatry programs really, I think there was a real benefit. There was a period of time called the decade of the brain.
Yep.
And I think it was during that decade that psychiatry really made tremendous strides in really understanding the underlying neurobiological correlates of mental illness, okay? And I think that was huge. I think it was major, and I think it is something that I'm very proud of, the field that I'm in, and I think that, we need to continue to make progress. This is probably, it's think about it, it's the only field in medicine where, we're very limited. It's not like we have diagnostic tools. I don't have genetic testing for depression or bipolar, everything we do is really based on a clinical diagnosis. So we do need to continue to make scientific strides. However, I think what happened is we moved away from really working with people holistically and really understanding people's psychology. And, we talk about the biopsychosocial model. However, I think we moved so far afield to to really focusing primarily as if, we're only focusing on the brain and the neurobiological underpinnings of emotional suffering, but we moved away from the individual. So I think for a lot of psychiatrists who really want to be good at doing therapy, I really felt that the only way I could do that was really to pursue psychoanalytic training. So imagine, after 4 years of med school, 5 years of residency, I then applied for analytic training, okay, which to become an adult, the stories are pretty bad. So to become an adult psychoanalyst, it took me 8 years of training, because part of the training requires you to see 3 adults in psychoanalysis as part of your training program. We call them control cases. So you have to see them now, psychoanalysis is 4 times a week therapy. Wow. And we use the analytic couch. So it's people laying on the analytic couch, you're sitting behind them, and then you have to do 3 cases over the course of your training. So sometimes the reason the training takes so long is because it might be, it takes time to, let's say, work with people or to find people that would be interested in undertaking that level, that depth of treatment and therapy. So it took a while to finish that. And so after 8 years, I finally graduated as an adult psychoanalyst. And then, of course, somewhere in midway, I'm also a child and adolescent psychiatrist. Yeah. And I decided that I wanted to be a child and adolescent psychoanalyst, as if I had not had enough back before. That took 10 years, Whoa. 10 years to finish that training. So that training was a bit harder because a lot of parents, it was very hard for parents. There you had to do three children, but you had to do adolescent, latency age. So we're talking like a 7, 8, 9, 10-year-old. Yeah. And you had to do a preschool kid, like 3, 4, 5. And it was very hard, I think, for parents to really understand the value of having a child that age in analysis. It would have been, it was very difficult, because a lot of parents, I think, they feel like having them come to therapy 4 days a week just takes away from other things that are very important. Sure. The thing is, there are times when you are seeing, for example, I do see children that, for example, that even at age 4 and 5 are really struggling with very severe levels of depression. Mm-hmm. I'm not going to tell you that it's common, but there are kids that are really, or for example, have very severe phobic symptoms where based on your assessment, there are indicators that some of the issues the kid is struggling with may run deeper, mm-hmm. that it may not just be simple things that the kid's going to outgrow. Mm-hmm. So a lot of pediatricians will just tell the parent, don't worry, the kid's going to outgrow this. But some issues are really issues that portend a more severe, more chronic course for some kids. So I ended up going into child and adolescent analysis. It was very hard. I was able to end up seeing 3 adolescents in analysis 4 times a week. And I even had one kid coming 5 times a week. So I was very, very fortunate to have been able to develop, and so I ended up on a different track and became an adolescent psychoanalyst. So today I primarily I'm a child, adolescent, and adult psychiatrist, but I also do my own therapy, and I like working with my clients individually myself. So I call myself a one-stop shop. So, you can come see me, and I can do if there are, treat any kind of underlying biological parts of the condition, but I can also address personally the underlying psychology.
That's why I said your background, your experience is so uncommon these days.
It is very uncommon.
And it's unfortunate. You put a lot of time and energy and hard work into getting where you are today.
And Terry, I'm going to tell you, people, first of all, a lot of people have a very bad opinion of psychoanalysis. Okay, so I think people think we're dinosaurs and that we're obsolete. So it's very rare, I think, for a lot of young clinicians today to consider pursuing a career, training in psychoanalysis. And it is a very difficult training process. It does require a lot of you. It involves a lot of sacrifice. However, I do think that it is something that I've seen myself be able to, it really can make a huge difference, because sometimes people do need something. Some people get turned off by the word intensive treatment. Some people get turned off by that. So the word I've come to use is treatment that provides a certain level of continuity. And it's not the same when you're seeing someone just once a week for 45 minutes and expecting that someone is going to be able to really substantially make the kind of changes that that person may need to make in their life. So what I see psychoanalysis or psychoanalytic type therapies doing is, one aspect is really providing a level of frequency that allows us to really get to those deeper rooted issues that are driving a lot of the symptomatic behavior. So sometimes you have to see, I think what psychoanalysts can do sometimes is look at what others look at as a symptom understand more of the meaning behind the symptom. What else might be going on behind that the symptom is just a manifestation of some underlying issue or conflict that the person may not even be aware of. And I think probably I imagine that a lot of the work you guys do is with, for example, so one of the areas that I've kind of been venturing into more recently is, so I've developed somewhat of an interest in working with a lot of people with narcissistic character pathology. So I'm doing a lot of work with guys, particularly guys with narcissistic personality disorder, many who have found their way either because of something in their life that basically losing their marriages, or for example, I'm thinking of an attorney that I've been working with where the partners basically asked him, look, you really need to get a consultation because you really have very severe anger management issues. So different people have found, and I think because sort of through those referrals, little by little, it became an area that I started to kind of learn more about and take more interest in. And so I think with people where you're dealing more with for example, we don't talk a lot today about underlying character issues. So a lot of people focus very much on what back in the day used to be called Axis 1 disorders. So the traditional depression, anxiety, bipolar, things like that. But a lot of times part of why some of these people really aren't getting better, or for example, one of the terms that gets used a lot is treatment resistance. A lot of people will talk about treatment resistant depression, or, for example, people talk about how people have to, for example, fail many attempts at substance abuse treatment. And I don't know, I think someone told me there's a study that you have to sort of do 7 rounds of going back to rehab before you actually integrate and really make the change, to maintain your sobriety. Now, I think there's truth to those things. The dilemma is, I think sometimes there are aspects of the treatment that go unaddressed. And I think sometimes it is the underlying character disorder issues, right? And I think that that's something that, I've become a big believer in. I call it tag teaming. Tag teaming, that's what I call it. Now, not everybody is open to tag teaming with Calderone, okay? But if you're open to tag teaming with Calderone, the thing is and I get it, some people feel, so for example, one of the treatment modalities that has gained a lot of support for is DBT, dialectical behavior therapy.
Yeah.
And I definitely support DBT. I think DBT is fantastic. The thing is, sometimes I think it helps to combine and tag team with different clinicians addressing different aspects. So whether it's working with a family therapist who can work with the family system, along with someone that's doing the DBT, while I do more of the psychoanalytic psychotherapy or even an analysis, where we can tag team together and work collaboratively. The thing is, sometimes there are therapists who feel that in order for certain types of therapy to be effective, that someone has to be immersed only in that model, only using that sort of frame of thinking. So I get the concept that some people may need to be immersed in one approach. However, I think in terms of helping people get better, I think if we don't address the different aspects, even if you do it, for example, sometimes I'll do it in stages. I'll say, all right, why don't we start with a DBT? Let's check in 3 to 6 months. Let me see where you are in your own progress with a DBT, and then we can reassess, and maybe I'll come in as a second stage. However, I have over the years found people who are willing to tag team and work collaboratively to integrate these different approaches.
You have to, because we know, data shows, evidence shows us that you can take CBT, DBT, REBT, EMDR. You put them all on the board and you say, which one has the greatest efficacy? And the answer is, they're all about the same. The one thing that you have that's the most important is the ability to create a therapeutic alliance with your patient. Because you can use any of those modalities, but if you can't create therapeutic alliance, which knowing, because we've worked on cases together, we've tag teamed together in the past, that your patients love you. They love working with you because of who you are. You create that therapeutic alliance and that connection, which is magical, absolutely magical. When being a psychoanalyst and psychiatrist, you see, I know that, because you work with young adults, adolescents, and adults, you see a lot. Are there any things that you can say, boy, these last few years since the pandemic or since school shooting, these are some of the common trends that I'm seeing in patients that come up regularly? Are there any themes that come to your mind that you've been treating that, like, wow, we're seeing a lot of this?
Yes. Terry, I would say that for sure. I think there is, I think everyone's probably heard, there is a massive epidemic, I think, in terms of adolescence. But I think it really goes beyond that. The rates of anxiety, depression, I think are clearly, have been on the rise. And I hate to admit it, but COVID was the best thing that ever happened to psychiatry and mental health clinicians. I mean, we were all just inundated. And I think for many different reasons. Obviously, we know that being in a quarantine is the level of isolation, and kids were cut off from their friends, and so we know the impact of that isolation, and the quarantine really had a tremendous impact on people's mental health. Now, I will say, in general, I think that there are rises in anxiety, depression. I think the other thing that I think is the other two things are, I think, talking about substance use disorders. One of the popular things that, apparently the liquor industry had one of its best years during COVID, and apparently people were ordering in through Uber Eats or whatever, Postmates, going to the liquor store to bring them. So apparently that was, and people were having, wine and cheeses online. So clearly, I think there were huge rises in substance abuse. I'm also going to say, and it's interesting, I've seen a lot recently also of other addiction disorders, not necessarily just substance related, but for example, gambling. So I've been dealing with a lot of young adults with very severe gambling addictions how much of it is the online access, but I think when you start talking with these guys, you realize that the gambling addiction has been serving a similar function to other things that people can use in an addictive way. So I've been seeing a lot of that as well.
And a tsunami.
It's a tsunami. It's a tsunami. And I think when you look at, again, the impact on the family and other members of the family, and a lot of times, family members mean well. So you have a lot of parents parents and family members and spouses coming into the rescue and rescuing them even to their own detriment. However, thinking that, we'll rescue them this time, but not necessarily always. A lot of people are very scared to confront the issue. Mm-hmm. Okay. For example, I had a recent call from a family of a physician with a very serious gambling problem, mm-hmm. and they never came to treatment. They never showed up. So again, I think a lot of families become very scared of having to address and really confront the issue. And so I do think those are very much, I think there is a tsunami of mental health issues, the rates of, people going to the emergency room to seek, to get help. And I think the other thing that I would add, Terry, that I think is something that I think there's two things that, like say, beneficial things that have come through, I think, in the last couple of years too. I think one of them is, I think we're appreciating more the impact of trauma. So I think that's one of the positive developments that I see is I think we do understand more and more the role of trauma. And I think in all of the conditions that we're talking about, whether we're doing substance abuse disorders or other types of addiction or anxiety and depression, oftentimes the people we're working with, if you really get to know them and you start finding out more and more about their own life experiences, oftentimes people have really been struggling with a lot of underlying trauma mm-hmm. histories and unresolved trauma. Mm-hmm. So I do think that one of the beneficial things that I've been seeing is I think a lot of programs are now becoming what they call trauma-informed mm-hmm. treatment. Mm-hmm. And I have to be honest, I had to Google it. I Googled trauma-informed because I started hearing
trauma. Yeah, versus trauma.
I started hearing this terminology, trauma-informed. I'm like, and back in my day, when you were in training, I don't remember the word trauma. I know that sounds ridiculous, how you could have gone through all these years of training.
For medical conditions, but not for...
And that's the problem.
Yeah.
So I was trained, and I have to tell you, that's been something I've had to work against, right? Because mm-hmm. I came from a medical model. Psychiatry gives you a medical model, and mm-hmm. I think it is a useful model, but it's also, you have constraints. Yeah. So I think you're right on. So we come from the school of, what's wrong with you, mm-hmm. and then we pathologize you as a person, or you have this diagnosis, or you become a diagnosis. Oh, the schizophrenic or the borderline. And I think that's really been detrimental, right? I think that is
what happened to you.
Exactly. And that's when I Googled it. I wanted to find out what's the difference, right? And and it is a fundamental difference, right? Yeah. It's a fundamental difference. And I think there's more room to heal. Mm-hmm. I think there's more room for recovery and healing when you're coming from what happened to you. Mm-hmm. And then you begin to start understanding your own, let's say, what are your survival mechanisms? How have you been coping? Mm-hmm. And obviously, look, a lot of people have turned, the most common thing is substances, or food, for example, is another, it's a much more easier substance to access sometimes. So it's often a way that people have been coping for many, many years, dealing with, sometimes obviously it might be anxiety, depression, but also underlying impact of trauma. So I think that's a huge piece.
At Prospect Hill, being in a place, a healing environment, right on St. Croix, U.S. Virgin Island, in this spectacular setting overlooking the water, just the being on the grounds is healing. And then we have a large group of gifted trauma-trained therapists with EMDR and other modalities to help work through that trauma mm-hmm. in that environment in a residential setting to get somebody going so that they can come back and continue that kind of work with you and psychoanalysis and continue the trauma work when they come home, but in a place now where they're ready to continue the healing. Very rather. Important. So I know from working with you that you treat people of means and prominence that come from wealth and come from means where, we get those same people. We're a small program, seven clients at a time at Prospect Hill. So these people that are coming, a lot of people look at them and they say, how can they have a problem? They've got everything in the world. They have houses in 3 countries and, all the cars they want and education and family, but yet they're miserable, right? What is it? What do you think it is about that type of client that you see? What's, that needs our kind of treatment at Prospect Hill? They need to come to Prospect Hill. What are the trends that you see in those people, and how do you treat those people that look like they shouldn't need any kind of treatment at all?
Mm-hmm. So, Terry, what I would say, I think there's a couple of, let's say, themes that I find in my work. I think the first thing, and you hit on it, right, is I think oftentimes a lot of these people have actually potentially grown up in what I call an invalidating environment. Or, for example, we talk a lot about growing up in a dismissive or invalidating environment. So even though, you've grown up having access to resources that potentially, let's say, can give you certain access to opportunities, however, you've grown up sort of always being told that basically anything that has had to do with your emotions or anything that has to do with anything in the realm of emotion, psychology, feelings have been dismissed or invalidated because what do you, for example, and I get this all the time when I work with kids. The thing is, remember, these little kids that I'm working with eventually become adults that you're seeing at Prospect Hill, right? So, right. Imagine when you're growing up being told that, what are you depressed about? You've got everything, you've got it all. How can, so you start to think like you must be the one with the problem because, you've been told that you have it all. And the thing is, we also know that sometimes not only have you grown up in a more invalidating or dismissive environment. Now, why is that important? It's very important because, so growing up in an invalidating environment, we know, for example, there's a field that I happen to I kind of like this field. It's called developmental psychopathology. It's very fancy. There's this big fancy guy. He wrote these textbooks. They're like this thick. I did not read them. I almost bought them. I didn't buy them. But volume 1 and volume 2, okay? But I'll tell you why I like that stuff. Developmental psychopathology, these people are really trying to really understand how do we get to the point where someone develops a borderline personality disorder? How do we get to someone that has a narcissistic personality disorder, right? And I think that from whether it's a treatment perspective or a prevention perspective, that's critical for us to understand what went into this.
What's the root cause?
What are the root causes and how do these, so imagine if you've grown up in an invalidating environment where no one has ever validated the way you feel, because technically you shouldn't feel the way you feel because you've got it all. Right. So you never really develop so I think there's 2 paths. So for example, the 2 main pathways that people think are related to, for example, to the development of narcissistic personality disorder. So we have 2 ideas. One is that people have suffered neglect and some degree of some kind of deprivation. But it's emotional deprivation. So imagine, sometimes you come in an affluent family, but dad's never around, right? Dad is on a plane 250 days a year and running a major corporation or, there's this family, but for example, I have a client who always tells me, we never relate as a family. Everything is transactional, or every time we come together, it's like as if we're in the business. It doesn't have the sense of cohesiveness of really being in a family where you feel that sense of genuine support. So I do think you got to take those things into account. That yes, you do have better access socioeconomically, but it doesn't necessarily mean that you grew up in the healthiest of environments in terms of emotional growth and development. So I would say that, affluence doesn't necessarily, it's not yes, it can be a protective factor in certain areas of life, but it doesn't immunize you from depression, anxiety. And sometimes what I always tell people is, sometimes growing up in a family like that, for example, I developed another niche area. Okay, so this is my other expertise. This one was a little earlier in my career, but I developed an expertise on slackers. And it's a very lucrative field for guys like me, right? When you get to treat the sons of the CEOs, right? Where the dads are like making the buku bucks, and then I get the sons that are losers. Right? That's that's another area of expertise that I have, right? So I learned how to work.
And that label loser is probably
and they were labeled losers.
From the father.
Correct.
From the father, from the family.
And that is how they've been perceived, right? That is, and they've been cast in this, and it becomes I call them SLBs, right? Self-limiting beliefs, right? Yeah. It's a big SLB, right? You've been a loser your whole entire life. And I'll tell you, I have what I call the Dr. Calderone poster children, right? Like these guys that, for example, one is thinking of a 27-year-old guy who had failed out of like a top engineering school, then, came back to Miami, failed out of, local college, and then at age 27 was sitting in his room doing nothing with his life, and his doctor was a very well-regarded, prominent physician in the community, and the guy's doing complete loser. Comes to see me, and it was the whole treatment. It really became about how he didn't ever feel that he could ever measure up to his father. So sometimes we don't realize the pressure these children have of growing up in a family where there has been the success, or where you have parents that are really larger than life, parents that have been themselves very successful in their professions, have done very well, are very well connected. And, so some of these kids have really grown up with a tremendous amount of pressure. And sometimes I always say that self-esteem issues, I say they either come bottom up, but sometimes self-esteem issues come top down. And what I mean by that is that sometimes what makes us feel bad about ourselves is that our expectations are so high or so unrealistic, or we're driven by these perfectionistic standards or these ideas of what we're supposed to be, that whatever you do achieve or whatever you are achieving never always pales in comparison. So you never feel good enough. You never feel like anything you do is ever good enough.
And do you mean self expectations, or both, the combination of others' expectations for me as well as myself, or? So
that's a great point. Now, so part of what you're hitting on is where the kind of work I do is geared towards addressing those, both for example, the expectations. So a lot of people, and even adults sometimes, are still stuck doing battle with what they feel are the parents' expectations of them.
Yeah.
Okay, there are people that are adults that are still stuck, struggling with that. But sometimes part of my job is really to help them disentangle from those kinds of external expectations. But also a lot of times, a lot of the people that I work with, part of the tendency sometimes is to keep their issues external. So a lot of the people, and I'm sure you work with a lot of these people where, so we have a lot of people that, a lot of people are familiar with externalizing blame, right? Where they shift the blame to someone else. Well, I deal with a lot of people where they've never really come to terms with their own internal set of expectations. Or for example, dealing with your own internal critic or your own internal judge. So a lot of the times the work I'm doing is really reworking one's relationship within oneself and how I relate to myself within those expectations that I have or those ideals that I've placed on myself. So I think a lot of the times the people that we're working with have often never really even understood what their issues are. Because for a lot of them, they feel that the issue is my spouse or, it's my boss. A lot of people will come to see me where they really, and again, it's not to minimize. And again, I always say, I'm not trying to minimize the impact of these external forces. We know that societal forces and cultural forces, social media, we know that these things impact. So I always have to, I use that concept from DBT, walking the middle path. I always walk the middle path where I don't want to minimize any of these external factors because they are very relevant, but sometimes people keep it all outside of themselves. And I think to really achieve the optimal healing and growth from, people that have been really struggling and having a lot of emotional suffering or traumatic, a lot of unresolved trauma, sometimes you really need to help them come internal to themselves. And that's why over the years, the other thing that I would say that I've learned, and I've learned it the hard way, and this is where I think having the analytic training experiences have helped me, is that, so sometimes when I have people that come in with, let's say, like a real major clinical depression, sometimes that's the best thing that's happened to them. And you should see their faces. It's like that face, right? When you tell them this is the best thing that's happened to you, and they're like in a massive, major depressive disorder. But it really is because finally things have caught up to them. And sometimes that is, people say, you got to hit rock bottom. The thing is, this is another version of it, right? Sometimes people really, things have finally caught up to them, or they've suffered some consequence of the way that they've been coping, that, let's say, that they've been coping in ways that ultimately become very self-defeating, that maybe work in the short run, but in the long run finally catch up, right? So a lot of times that depression is really not, let's say, a formal, what I might say, it's not like you're going to have, there are people that have recurrent depressive disorder, for example, but there are people where they've fallen into a depression as a result of everything that's been that's finally catching up. So sometimes that actually becomes a blessing in disguise. Wow. Because that is what then opens the door. Maybe it's the first time they're seeking help with a therapist or a psychiatrist, and sometimes that's what opens the door to getting the treatment they need.
When people come to Prospect Hill, the clients get, in that first week, they're going to get their psychiatric evaluation. If they don't come in from a referent like yourself, that's going to prepare us with that full download of information. So they'll get the psychiatric evaluation with Dr. Sonnenschein. They'll do a full battery of psychological testing, neuropsych as well, and to identify what's going on with something you mentioned earlier that I'll come back to. Nutritional, biopsychosocial, full evaluation, so that if someone's coming in and they haven't come from a professional like yourself, we have to do that initial download of information from them, the family, to decide in that first week, what's our plan going to be going forward while you're here at Prospect Hill, and start working on continuing care and saying, okay, this guy's from Miami, he's unattached, he's not working with anybody, he needs to go to Dr. Calderone because he'll continue the great work that you're talking about doing. So you talked earlier about identifying the personality stuff that's really, everyone's focusing on Access 1, what was called Access 1, psychological conditions that are biological and biomedical conditions, and forgetting about the importance of looking at personality. You talked about narcissism being one of those, and identifying that. When you look at a place that's in the Caribbean, patient's going to be there for 30, 60, 90 days. If you're working there, what kind of work are you doing with that patient? What do you think needs to happen in that period of time when they're in residential treatment?
Terry, I'm going to go back. Let me go back. I do think there is one biological issue in terms of psychiatric that I want to mention, because I think it's something that I've missed a lot in my patients, and that I think is relevant for the work that you guys do at Prospect Hill. I think I want to bring up the issue of bipolar type 2 conditions. So over the last couple of years, I have missed diagnosing several patients that have actually had underlying bipolar disorder. And so when I started doing a deep dive to kind of figure out what's going on, and obviously I was, feeling kind of, I took a hit, right? I'm like, diagnostically, how did I miss this? So it turns out that when you look at the research on bipolar type 2, the research indicates that it can take upwards of 10 years, of a decade, before people are formally diagnosed with type 2 bipolar. And the reason, and the thing is, so imagine someone that has had underlying bipolar illness for over 10 years and no one has picked it up. Okay? Now, I think when I reflect, I think there's fundamentally, so one of the reasons I think it doesn't get picked up, and it's very relevant, and I'll explain why it's relevant to the work you guys do, is because, first of all, bipolar type 2 is a type of bipolar illness. So bipolar illness is what in the past used to be called manic depressive illness, manic depressive disorder. So it meant that people would fluctuate between periods of mania and periods of depression, and that they could cycle between periods of depression and periods of mania. So bipolar type 2, I tend to call it a soft bipolar, but don't take the word soft as innocuous. It turns out that when you look at the impact of bipolar type 2, it's actually very severe, very disabling condition. And imagine when you've had a condition like bipolar that has gone undetected throughout your, a decade of your life. So the thing is, there was a very famous psychiatrist, Dr. Akiskal, who started developing, he came up with a list of like 7 different types of bipolar illness. So the thing is, he found that there were high correlations between a lot of people with bipolar type 2 were very prone to substance use disorders, okay? And they suspected, to what extent have they been using substances to almost attempt to self-regulate, okay? Now, the reason I want to make this point is because I want to be careful that we continue to always integrate, that we not miss something that potentially is really, there is a very real neurobiological illness going on that genetically this person's, and because the problem with bipolar type 2 is that people have what they call hypomania. They don't have a full-blown manic episode. So what happens is a lot of times when people have a full-blown manic episode, it's very noticeable. People may even become psychotic. So often, a lot of times, family members will be able to notice a very marked difference. However, I could see a lot of the people that we work with and a lot of the people you work with having traditionally being people that may look like, they're running at a very high level. Like I talk about, for example, I use a lot the mode, like the RPMs, right? Yeah. Like mania would be like you're in the red line. Yeah. But a lot of the people we work with spend a lot of time in the 5, 6, 7. They're always revved, right? They're always revved. Now, the problem is you can misdiagnose that often as ADHD. Right. A lot of these people have like very, and a lot of these things overlap. So it can look very ADHD sometimes. And then the other interesting thing is when they looked at the studies, a lot of the people with bipolar type 2, actually, they spend most of the mood episodes are on the depressed side, on the depression phase of the illness. So what I noticed, when I started doing sort of like a chain analysis, like working like a reverse engineering, like why did I miss it? How come I didn't pick it up? I think what would happen is a lot of these patients were coming in they would be depressed. Then they were cycling into, let's say, a hypomania, let's say level like RPM 345, and I'm thinking they're getting better. So, and everybody in the family, everybody was like, oh, this is great. You know, Johnny, you know, seems better. He's getting, right? And they're, you know, and they're more animated and they're, you know, they feel like they're back to themselves. And it's really a hypomanic episode. So it is a very challenging diagnosis to make. I've missed
mood
it.
Stabilizers or
correct. So it is. So you use similar to what you would use for bipolar type 1. You would use mood stabilizers primarily. So, for example, medications like Depakote or what we call the second generation atypicals that we know provide a lot of mood stabilization as well. So it is it is tough to treat these conditions medically. However, there are good treatments available. Lithium is something that is sort of, we're rediscovering lithium again. So in the field, we're rediscovering the role of lithium because lithium is really continues to be one of the best mood stabilizers in the treatment of bipolar. Obviously, it has, part of the reason we moved away from it was because it has challenges in terms of, it has a very narrow therapeutic window. So, but I wanted to mention that because I suspect that one of the things that I value a lot, for example, one of the things that I value about being in residential treatment and having a long-term stay is having the staff be able to monitor and track and help, because sometimes, even though I may have done a good assessment, there are times when I miss something, and I really value the feedback diagnostically of being able to see someone daily, observing and correct. And being able to see them in multiple settings and kind of being able to kind of track more the mood fluctuations.
When you talk about somebody being at 5, 6 RPM and they're a bit revved in the hypomanic states, are they also showing the typical crazy credit card spending, sexually acting out, or is that not always some of the characteristics?
And I think, so the answer is yes, but perhaps, again, more at a 3, 4, 5, not red line. So for example, I might have a full-blown manic patient, I'm thinking, who the spouse went on a family trip somewhere to visit family and the person bought a car and new laptop computer, like it was, so we're talking about people that, yes, there is more of that behavior, but you could almost discount it. You could almost, it's just, there they go again, kind of. So I do think that it's something you really have to have top of mind. Diagnostically, I think we need to keep that in mind. So I would say that's one of the things that I feel like I wanted to make a point of.
Super important, because if you don't treat that in a treatment environment,
correct,
and Prospect Hill gets that type of client, has the opportunity to treat, observe, give feedback, and identify that. And then, as we're starting the continuing care process, meeting with you, getting ready to tag in, Dr. Calderone in Miami, that information is going to be hugely important. This is what we've observed in this period of time.
And I do think that often in my experience, I work in an office-based practice. And so I don't have the resources that a program typically has. And one of the things is oftentimes it is safer, more ideal to be able to offer any kind of psychopharmacologic intervention in a setting where you can monitor every day and monitor vitals and monitor side effects and be able to stabilize someone in a setting, as opposed to me trying to do it, with someone who is, going through something like that, but without any real containment or structure, and it becomes very, very difficult, and it's not
usually not a very healing environment.
Correct.
Not a very healing environment. We're proud of what we're able to provide people, and we have seen exactly what you're describing. We've seen those types of clients and been able to help them. Dr. Julio Calderone, you're a hero of mine. You know that, and I appreciate you.
Thank you.
And your
Thank
time.
you. You're the best. Thank you.